We've been talking about insulin the whole time, right? I remember I did say that insulin typically for the type 1, but there comes a time when the type 2 person can use it, right? When they are really going a little higher and their pill is not as effective, then they may need it. So the medications for the type 2 person is called oral hypoglycemics. That's what it's called. Remember I told you they have different effects and they are given for different reasons. So insulin, when you look at it, think about insulin, it is in terms of action, right? Different insulin have different effects, different action. So once we're, your goal is to know what these insulin are, the different types, and their action. And so it's interesting, the technology about insulin, how they have all the different types and the effects they have on the person. So we have ones that are very short acting. So you gotta know the different types. It's on a table in your book. So you gotta learn that table and know it, in the back of your head. So when somebody, I know it's hard, it's a lot, it's so confusing a lot, right? But the more you study, the more you practice, the better it will be for you to remember. So there are very short acting. That means once you give that insulin, how long does it take to start working, right? Because we want it to deal with that glucose, right? We want to decrease the length of time they have that high glucose circulating in their bloodstream. So very short acting can even be effective with anything as from 10 minutes from the time you've given it to them, right? Could be 10 minutes to 15, right? Minutes onset of action. So insulin, you have to think about it in terms of the onset of action, the peak, the most effect, and duration that it's still in our system. How long it is still working within our system, right? So that's how you see insulin. Once I give it, example, Humalog, it's a very short acting. Within 10 minutes that you give it, so it starts working. Then it has a peak action, up to about, I think it's 39. You have the table? Okay. What's the peak action for Humalog?
30 to 90 minutes and the duration.
30 to 90 minutes means an hour and a half, right? So up to an hour and a half, and duration?
5 hours.
So in 5 hours, it's still in the system, right? Still within that person's system, still working, right? So you gotta know this insulin based on, their onset of action, the peak action, the duration. These things are necessary. They are necessary in terms of how you plan your care for your patient, right? So if you're gonna give somebody insulin at, the breakfast comes at 8 o'clock, and you want to give them insulin at 7:30. What's the onset that's written in the book for Humalog? 5 to 15. So from 5 minutes up to 15, it can start being effective. So if their food comes at 8 and you have 30 minutes, should you give it? When the onset of action is from 5 to 15, it starts working. All right, so these are you have to know these things in terms of when to give it, when to administer it to your patient, or when you will teach your patient to take it, because a lot of them are home, right, and they have to take it. So if their breakfast is coming, it's not when the breakfast is coming 1 hour later, peak action, 30 to 90 minutes. So if the breakfast, let's say you're working night, you have to finish your work at 7. You do your blood sugar at 5. Breakfast doesn't come until 8. Can't give them insulin at 5, 3 hours. It will already drop their sugar and they don't have the food. So you understand how it works? So you have to use that to inform yourself in terms of how to plan your care. Okay. The other one is regular insulin. The onset of action, 30 minutes?
Yeah.
30 to just 30 minutes? Regular insulin, the next one.
30
That's
minutes.
10 to
30
20.
minutes.
No.
30 and the
regular.
regular says 30 minutes.
30 minutes is the onset. So regular is called very short acting. Okay. So Humalog is very short acting because the time is so short that it's more. It starts working right away, 5 to 15 minutes. Regular it's 30 minutes onset of action. It starts within 30 minutes. So if the food is coming in half hour, yes, you can give it at 7:30 for breakfast at 8, right? So the other one is now NPH, which is, okay, talk about the peak of regular. What is the peak of the regular?
2 to 5 hours.
2 to 5 hours. So if you give it at 7:30, count 2 hours from 7:30, from 9:30, it's going to have the most effect. Remember, the insulin is going to bind with glucose, drive it into the cells, and their level of glucose will drop. Right? So the glucose will not be circulating. But when you check their blood glucose level, it's going to drop. It can drop lower than this. When we say peak action, it's remember, the insulin binds with the glucose, drives it into the cell, locks it away, and then in the bloodstream, you check it. 2 hours later, if it was 200, and you haven't given them breakfast, I'm saying if you haven't given them food, you've given them something, in 2 hours, it can lower and they will have an acute reaction of too low. See, there has to be a balance. If it's too high, they have a problem. If it's too low, they have a problem. And they will have symptoms, which we're going to talk about, all right? So route of administration, the rest of them, in that your chart, they have intermediate NPH, insulin, intermediate, then they have long-acting insulin, Lantus. All right, long-acting. Long-acting, the difference is that it has no peak. And you gotta learn these things. Okay? Lantus, Levemir, right. These are examples of the long-acting. So for 24 hours, they are effective. They're still working. All right? It doesn't peak. Doesn't have the most action. But the Humalog, regular, NPH, they have peak action. The important thing about the peak action is that you expect when it peaks, that's the time their sugar can drop. So around the peak is the time we give them snacks or we give them food, because we don't want them to bottom out. That's the significance of peak of the insulin, okay? Insulin is given subcutaneously by injection. Sub-Q, right? Subcutaneous injection to the fat tissues, right? It absorbs better there within the subcutaneous tissue. Now, IM, they have what's called glucagon, and glucagon is not insulin. When somebody has low, you can get the glucagon. Remember I was telling you the liver will release glucagon? And it will become a source of glucose. Now they have glucagon injection when people's blood sugar drops. What is called the hypoglycemia, right? They drop and they have the symptoms. Drops too low, much lower than 70. They have the symptoms of low sugar. Then you give them a shot. The people who get the shot are the people who become unconscious. They can't drink a cup of juice. You can't eat anything. Remember fast sugar? And when they're awake and talking to you, they can eat. But sometimes it's so low, they pass out. You want to find a person before they die, because they die from there. Because it's low sugar. Remember? Self-starved. They die, they go into coma if we don't catch them, right? So they give them, those people when they are unconscious, you give them an injection of glucagon, they wake right up.
Wow.
Right? Yeah, they wake right up. Sometimes it doesn't always work. But it should work. It works a lot of
Let me
times.
get some. The routes are subcutaneous, IM, and inhaled.
So I'm talking about the ones that can get Right, they have different ones, yes.
IM is glucagon.
That's what I'm talking about.
Insulin, no IM.
No iron, it's subcutaneous.
Only subcutaneous.
Yes, only, yes, that's good the way you said it, yes. Insulin, we give to our patient the MPH, the Humalog, the regular, the Lantus, it's only sub-Q, all right? There's, the new technology, they're working on things, trying to get different ones, trying to get the ones that the people can inhale, all right, but they're not really not being used. So they're still working on that new technology, all right? Then they have insulin pump. Insulin pump where that, they have the pump and it is threaded under their skin. They wear it like a little box on their waist. And it is able to check their sugar. They can get their results. And they know how much their glucose is. And then they can set how much insulin based on the glucose they got.
How is it attached?
It's attached to their skin.
No, I'm saying inside like a needle or something?
Yes, under their skin.
Okay.
And so they can press that little box and get their insulin dose. Yeah, it's new technology. It's really cool. So people who travel, people who go out socialize, they like that. They have, maybe they have a job that they have to travel a lot. They have to go and visit people. They don't want to be walking around with needles, right? So that works really good. They find it really, useful. And then they have the insulin pens. A lot of facilities, hospitals have the pens. Pens are multi-dose valve, multi-dose. It's not like the bottles that you have to draw out insulin. Right, that's what it used to be. Now they have the pens. Multi-dose, it can last like months, depending on how much the person needs. So on that pen, you turn the dial to the amount that they need. The only thing you need to do is to change the needles each time. Multi-dose, you just turn it. If they only need 2 units, you turn it to 2. That's enough, and you just turn it to 2. If they need 4 units, you turn it to 4 units. You give it, you press it, the dial turns to 0. But there's still more in the
You have to take the
pen.
needle off.
Yeah, you just remove the needle each
I just
time.
have a quick question for those kinds of pens. Did you ever hear of Victoza? Is that insulin? That's not insulin.
Which one?
Victoza?
It's new. I'm not sure about
I know
that.
they do it like that because my dad's on it. He has type 2, but it's not insulin. He takes the pills for it and then takes the sub-Q shot with Victoza.
Okay, it might be related to the oral. Right, but not oral. They have newer technology. More and more stuff come out too. And that Victors, I'm not really familiar with it. I know they have newer things. They have different things. And each time they come out with. It's interesting. Why don't you tell us that in the next class? What is it really? Remember I said it is specific for the person. It may be to stimulate the pancreas. It may be to decrease absorption of glucose. It may be, they all have different effects. Yeah, it's really interesting. All right, so insulin pump, insulin pen, right? So another thing you need to familiarize yourself with the different sites where you give the insulin. When you go to the nursing home, you get your patient. You're gonna have patients who are diabetic. Now you have to give insulin. Remember, this is the landmark for insulin. Do you see here? Do you see this deltoid? It doesn't show you that you can give there. It's not IM. So you don't give it, a lot of times students forget. And where you're going to give it, somebody goes here. No, you don't go to the deltoid because you're giving it in the muscle. You have to give it in the fatty part, adipose tissue. You see the landmark. So always remember, you see here in the front and in the back here. Those are the places you give it. And then, the stomach, away, like 2 inches away from the umbilicus here. But 2 inches away, most people, they just go there, next to it. No, it means that whole area you can give it. You see where the numbers are. You give it that whole area. And the same thing goes here. And you rotate. You must rotate. Site rotation is important. So if you give it, let's say, you see how they number it to help, remember, you can give it on the site 1. right, for morning, and for the afternoon, you can go to 2 here on this side to give it. Just rotate. Even if you give it here, you can also give it on 2, right? As long as you remember to rotate the sides. You don't want to give it in the same spot all the time. It damages the tissues there, causes a complication called lipodystrophy. All right, so you must rotate sides. Learn to rotate sides. Remember we talked about onset, the peak, and duration. All right, okay. Here's the insulin pump, right? See how it's attached to the skin? Okay. And they can press it with a little catheter and they get their insulin dose there. All right, and oral hypoglycemics, remember? They are not insulin, right? They are pills to do specific action. And it depends on the medication, okay? They may increase the tissue sensitivity. So that person who has a lot of insulin but is not sensitive, so it may be a medication to increase tissue sensitivity to the insulin sensitivity to the glucose. It may be one to decrease absorption, right? Digestion of carbohydrate or absorption of carbohydrate. So it depends on the time. All right? And in your book, there's a page with all the different oral hypoglycemics, right? And examples. So these are newer developments. They're not really being used. Byetta and Symlane, newer developments for but not really being used. Now, important thing about the diabetic patient, they must know how to do self-monitoring of blood glucose. Right? Self-monitoring. Any diabetic patient, they're not always there with a healthcare provider. They're not always there with a nurse. They are home. They must learn to manage their diabetes. So it's called self-monitoring of blood glucose. That means they must know to check their glucose levels before meal, AC, right? Before every meal, before breakfast, before lunch, before dinner, and they record it. And at bedtime, about 4 times a day. They must record their results, the results they get, and keep a record so that the next time they go to their healthcare provider, they take the results. Because the doctor will look at, let's see how your sugar has been running. Has it been, controlled well? Has it been? And, some of the paper where they document can say what they did. Maybe they went to a party and had this, birthday cake. Maybe it was their birthday today and they had to do that. Maybe they were too hungry, they had to grab whatever that is there. Whatever happened. So if they have an elevated level, they can write it there, the reason, explain it. So they must, part of self-monitoring, they must know to analyze. So if they get a result, of 260, what should I do now, right? For those of them that get that sliding scale insulin, they will say, okay, I know I've taken my pill now. Do I need insulin, right? For somebody who has an order. So maybe, I need to see how much insulin I can get for this result. So they need to understand how to analyze their results. If I get 300 now, what does that mean? For a type 1 person, if I get 300 blood glucose, the next thing I need to do is to take a urine sample, do a dipstick. I want to know if I have ketones in my urine. All right, so they need to understand how to care for themselves while they're home. Because they can't go to the doctor every day, right? They need to know what their target is. The doctor will tell them, our target, remember we're talking about postprandial, we don't want it to be greater than 200. 2 hours after we've eaten. So they need to know what the target is for them. The doctor usually will communicate the target glucose level. So for every time, for me to say that this person's glucose is under good control, each time before they eat and they check their blood sugar, I want it to be less than 130, right? I don't want it to be, or maybe from this to 140. Some of the doctors then. So I don't want them to be getting 150 before breakfast. I don't want them to be getting 160, something like that, right? So they need to know what their target is. And they need to know when to call the doctor, right? When 2 days in a row, if their glucose is a little higher, like getting 200, when it shouldn't be. If their target is 140, and today, like for the last week, they've been to 240. That's a problem, right? They need to know when to call the doctor. So this is like a diary that they keep, right? It tells them, what they ate for breakfast, lunch, dinner, right? And when they did. If their blood glucose is 302, then they decided, okay, let me check for ketones. They take urine, they do a dipstick, and they check for your ketones, and it's negative. You want negative ketones. You don't want ketones. It's a problem because they get sick when they have that acidity, right? When they have that, it makes them sick. They have flu-like symptoms, all right? Okay, urine testing, that's a dipstick. So they do dipstick, they need to know that they can do dipstick from time to time. Use the glucose. The dipstick will show glucose amount. It's on the bottom. It will also show if they have ketones. And I said if it's greater than 300, they check for ketones. Mostly for a type 1 person. That we know is prone to ketosis, and we don't want them to be in ketoacidosis, right? So alterations in blood glucose. Alterations, that means, when it becomes abnormal, right? Abnormal when it's too high or too low. That's hyperglycemia and hypoglycemia. All right? So that patient who has altered glucose metabolism, they have periods, or a diabetic patient have periods of time when they have acute reactions. They're called acute reactions. Okay? So you have to familiarize yourself. Acute reactions. So when you're asked, what are the acute reactions? You should remember that. It's 4. When you have hyperglycemia, okay, that's 1. Then you have hypoglycemia. Okay, these are acute reactions, right? Now there are others, 2 other ones. So here it's too high, right? Here it's too low. Now you have other ones here, which we call diabetic ketoacidosis, DKA. It's also under high, but this is for a type 1 person. Okay, then we also have another one. It's under high. Remember, I put them under high. The type. This is for a type 2 person now. This is an equivalent of DKA, except that there's no ketones for a type 2 person. So it's called hyperosmolar hyperglycemia. Okay, so you see that these are all acute reactions, and they are all alterations in blood glucose. They must be addressed. They have to be treated. You understand? They are acute reactions. So somebody in hyperglycemia, they are having high glucose levels. Hypoglycemia, they're having low glucose level. They have symptoms. They can die from this, okay? Now, the type 1 person can go into...
What's that smell?
Oh, is it this? No, it's this.
No.
It can't be that.
What else?
It smells
Like
like,
what?
it smells like a marker, but it's like
Like
a
what?
burning smell.
Like one cable or?
Burn plastic. It's strong.
Did somebody put anything on the...
Probably a new one.
It's strong.
Is it strong? I was smelling this. This is very strong.
Is that?
Very strong. I don't know.
That's she just started writing with it.
Yeah, I just started with it.
Is
It's
that?
so strong. It is?
Yeah. Make my asthma. It's like a marker.
Yeah, it's so strong. I just used it.
Yeah.
Yeah. I think that is.
It's
Right.
like-
All right, so those are acute reactions. Okay, so your goal is to know what they mean. What are the symptoms? Hyperglycemia, when the blood glucose level is greater than 126, greater than 130. Remember the goal for a diabetic patient, we want it to be less than 130. So if it's less than 130, right? I mean greater than 130. So what causes hyperglycemia? Why is it that a diabetic patient will have that high glucose, right? So they are getting insulin, they are probably getting their oral hypoglycemics. Why is it that all of a sudden it's out of control, right? It happens. And these are the reasons for the number that is high. The hyperglycemia. Sometimes we overeat. Remember I was saying
Too much like
eat too much. Especially you know, a diabetic patient, I told you, this person has been sentenced for life, right? That you can't do what you like anymore. But now you get tired of it. You say, you know what, I'm going to enjoy this food now. You fill up your plate, you eat it. Your body will suffer it. All right? So overeating, stress. Because the body responds, that negative feedback mechanism, the body responds by releasing cortisol. And cortisol, you think about it in terms of corticosteroids. Those patients who are on develop secondary diabetes because they have to take prednisone. COPD patients, they end up like that, you know. So stress causes increased cortisol. If you're stressing, you know, sometimes we're not happy about anything, right? Everybody's, when we have problems, it's everybody else's problem, right? We're stressing for no reason, right? That's not good for the body, right? Illness, the body responds by, releasing cortisol. Illness is another time that the person's glucose level goes higher because the body releases cortisol. All right, not enough medication. So if they're supposed to take 4 units every morning before they eat food, and then they have problem with their eyes. Remember I told you a lot of diabetics in the long run they get blind. So their eye starts diminishing in effectiveness. So before the pens came, they have to draw their insulin, and they have very poor sight. So they were drawing a good amount of the correct amount. So not taking enough medication can lead to that. All right.
Another clarification, we needed to find out what stress does to the body and illness. It lowers the sugar or the glucose or the insulin. What it does?
Stress.
Yes. And it raises the cortisol.
It increases cortisol,
Yeah.
and it is the cortisol that puts the glucose high.
Okay.
Yes, sends it up.
Okay.
Yeah, stress does it, and the body responds. Remember I was saying compensatory mechanism? So that's a compensation. So unfortunately the compensation is to meet up with that stress, but then it causes problems, All right, so not enough medication, all right? So those patients who are supposed to get sliding scale, maybe they just took their pill and didn't take their sliding scale. Remember I said they must learn to analyze their results. Know that if I have this amount, I need to take my pill plus, 2 units of insulin or whatever, all right? Okay, symptoms. Symptoms of hyperglycemia, the 3 Ps. Blood vision, they have very blurry vision. When that sugar is so high in their system, fatigue, they are very fatigued. The lethargy, right? Headache, abdominal pain, ketonuria, ketosis, ketoacidosis, the same thing, all right? Ketonuria, in their urine they have ketones. Coma, acidity, metabolic acidosis, they can go into coma, all right? Hyperglycemia can throw somebody into coma. And for the type 1 person, because of the ketones that are acidic, it will make them really sick, they can go into coma. It needs to be addressed. That's why we say they are acute reactions. Remember, somebody who is in the acute care hospital, they need to be treated. So these symptoms must be treated. Hi. Okay. Yeah.
So you're gonna go exercise and then out for the clinic, so you take the log, the fast acting. Yeah, absolutely. So take your insulin, exercise and increase that level, right? I know, right?
All right, this diabetes is so much. I never finish, right? So we got this, right?
Yeah.
And I was saying, acute, they must be treated. So treatment for hyperglycemia, we want to monitor the sugar, right? If they have a blood sugar of 400 and you do treatment, whatever the treatment is, so you're going to monitor more, right? You want to see that it comes lower. So you're going to recheck it. After you give the medication, half hour later, 1 hour later, all right, you have to recheck it. Use sliding scale, because a lot of times they have sliding scale. Those people who have problem managing their glucose levels, the doctor will now say, okay, I'm going to put you on sliding scale. So the type 1 person must get insulin, right? So sometimes they have a routine. They say they must have 10 units of insulin every day, right? That's their routine. But then if their sugar is greater than 200 or higher, then they need some sliding scale in addition to the routine. And the same thing goes for that type 2 person who gets the pill. And if it is a little higher, they need a sliding scale for the overage, okay? All right, so they use the sliding scale for the hyperglycemia. If blood glucose is greater than 300, check for ketones, right? And now determine what's the cause. Why are they in there? Well, is it any of those things that we talked about? The overeating, the stress, the illness, infection or anything. So they want to determine the cause and try to eliminate it. So if it's the fact that they ate too much, they shouldn't be doing that, right? If it's because they're stressing, they need to do stress reduction, right? Stress management. If it is maybe they're becoming sick. So that's how people kind of know, like diabetic patients, how they figure out that they're becoming sick. When all of a sudden their glucose level starts rising, something is wrong. Maybe they're coming down with a cold. Maybe they have some UTI. Maybe something, right? So treat the cause or eliminate the cause. If the glucose is greater than 180 for 2 days in a row, remember I'm saying they should know when to call the doctor, when to go to their doctor for follow-up, okay? So call the MD if they're falling sick or if they are vomiting. Ketoacidosis can cause those GI symptoms. When they start vomiting, if they are home, remember they are home and they're managing their glucose until the next time they have to go to the doctor. But let's say they didn't even check their ketones and they didn't even know. Or, so then they start vomiting. Ketoacidosis, it affects the electrolytes in the body. So they have an imbalanced electrolyte. So when you have abnormal electrolytes, you will be, vomiting, you're going to lose more electrolytes, right? So it's not good. It's going to make them sicker and sicker. So it needs to be treated, right? So it's not the time that they will stay home. They have to be treated, all right? All right, hypoglycemia, that's when it's low. Now, don't use this. Every time I've tried to correct this, but my flash drive won't let me correct it. It will tell me there's no space. So it's not greater. The blood glucose has to be lower than 70, all right? It's lower than 70. Sometimes, 50. Some people may have 50 and not be symptomatic. But some people may be at 40 and become symptomatic, right? Symptoms of hypoglycemia can be as low as 20, all right? It's acute reaction. It's a problem. It needs to be treated. So causes of hypoglycemia. Maybe they're supposed to get 2 units. Remember nurses make mistakes sometimes? Your patient's supposed to get only 4 units and you give them 10 units. Well, too much insulin. Or the patient's eye wasn't good enough and they turned it to the wrong one. Or even the nurses, you don't have your glasses today. How many of you will say, I don't have my glasses? and then you're gonna give insulin to a patient, you turn it or you draw it up and you can't see it well, and you think you had 4 when you actually had 8, right? And some of the needles are different. Some of them are increments of 1, some of them are increments of 2. You can't understand it, all right? You have to make sure you give them the accurate ones. Because when they're dependent on us, right? Exercise. Maybe they exercised and they didn't eat. That can cause a drop in the sugar, remember? Not enough food, right? They didn't eat enough. They're too busy, but they took their insulin. Remember, we're talking about peak action. And it gets to the peak action. Or we gave them insulin too early. You want to go home, you have to give insulin before you leave, right? You're on the night shift. You get their blood sugar at 5. You go and give them the insulin because you need to finish your work, right? And the breakfast doesn't come until 8. And they can't get up and go to the fridge and get food for themselves, right? So you're throwing them into hypoglycemia. You see that? So these are some of the reasons why they can go into hypoglycemic episode, acute episode, right? Signs and symptoms, you have to know the signs and symptoms of hyper, signs and symptoms of hypo. These signs and symptoms, acute conditions, you gotta know those. That's what knowing diabetes is all about. Headache, hunger, shakiness, right? Remember, their cells are starved. They have no energy in hypoglycemia, so they'll be shaky. Somebody who's going through hypoglycemic episode, shaky, diaphoresis, they start sweating, skin cold and clammy. That's how you know some of your patients who are not able to communicate. Maybe they had a stroke and they can't talk anymore. They're complete care patients, right? And they are diabetic. And the way you know that they may be going through hypoglycemic reaction, they can't tell you what they're feeling. So when you go there, their body feels so cold and clammy. And you check. Maybe they're not as responsive to you, okay? They're not responding that much. You try to wake them up and they're falling asleep. They're gonna go into coma on you. When it's too low, they can go into coma. So that's the time you go quickly check their sugar. Many times you will find that their blood sugar has dropped. Okay. Cold sweats, palpitations, shakiness, which is a fight or flight reaction, right? Neuroglycopenia, irritability, okay, neurological effects. They become irritable. Some of those ones I can't talk to you, but you can know when they become confused and they're irritable. All of a sudden, you wonder, this patient is not usually like this. Something has changed, right? You're confused, they don't, you're asking them their name, they're falling asleep. All right, there's a problem, right? You should know your patient. They can go into seizures, they can go into coma. Some of these patients, remember we're saying the complications that occur, they have nerve problems and blood vessel problems. So some of these diabetics, the major thing is that they don't have the sensation. Because of nerve damage, they lose sensation. So when they get hot, they will know. So that's why part of our teaching for our patient, they must wear their shoes all the time. Because they may step on a stone or a needle and would know it. Because they do not lose so much of their sensation. Right? You don't want to use so much hot water to bathe them. Because they won't be able to feel that it's hot because of the loss of sensation, all right? So that's part of, we need to be conscious of that. So treatment for hypoglycemia, right? You check the glucose, right? Remember, if they were 40 and they were symptomatic and we give them their weight. Remember I was talking about glucagon? When they go into coma, at night sometimes you actually can find your diabetic patient. You try to wake them up, you can't wake them up. They're breathing though. You go into coma, they're breathing, but you can't wake them up. And if you know they're diabetic, you check their sugar real quick. You may find that they are 40 or lower, 35 or 55, something. So you give them, but if they are not responding, you can't give them sugar. When they are awake, they have a 40, they have the shakiness, but they can eat, you give them a quick, fast sugar, give them a cup of juice, right? But you must go back and recheck after you've given them every 15 minutes until you bring them to a level that it's okay. till you get them to 70 or more. Can't leave them at 40, you give them a cup of juice and you walk away. No, no, no. They can go back down. Some people, it takes a while for them to come up, even after you've given them all that. All right? We check every 15 minutes and PRN as needed until they're stable. Okay? You know, you give them snack after they are stable. If it's going to be like over 1 hour before the lunch comes or breakfast comes, right? So you can give them something more. You know, you can give them a cup of milk. You can give them a little snack. All right. Fast sugars. These are the equivalents when they are in hypoglycemic reaction. These are some of the things you can use. If you have orange juice, you can give them 4 ounces of orange juice. That acts as a good fast source. Regular soda. That's the only time you can give them regular soda. Because you're looking for a quick sugar to replace. That's the reason why it's there. Not under normal circumstance. They don't want the regular soda. But in the acute reaction, if you don't have orange juice, you can give them 6 ounces of regular soda. If you don't have that, you have a box of raisins. You can give them 1 box of raisins. They're saying that these things are kind of similar amount of sugar that it provides to, treat that hypoglycemic episode. They have some glucose tablets that you can give, like 15 grams of glucose tablets. Some places do have glucose tablets. Or if you have 6 lifesavers, 6 to 8 lifesavers, you can give them. All right?
The peppermint kind?
Huh?
The peppermint kind?
Either one, yeah, lifesavers. 6 to 8. I hope they'll still be okay by the time they finish 6 to 8 lifesavers, right? It's gonna take a while to really finish, unless they're gonna chew on it or something. Acute treatment. Remember we're saying all these are acute problems, right? So now, acute treatment, hypoglycemia, you give the fast sugar. Now, if the fast sugar doesn't work, or they're not as responsive, this is what you give. Intravenous, when they're in the hospital and have an IV line, you give D50, push, IV push. Heavy dose of glucose. Remember, it's simple sugar, it absorbs right away. So they give intravenously D50, dextrose 50%. It's really thick solution. When you push it, it doesn't go freely. You have to kind of push it out, and it goes through the IV, and you flush it, and gives them quick. If they're really unresponsive, and you give them that glucose right away, boom, they open their eyes. It's really. And then subcutaneous glucagon, right? In the long-term care where they don't have long IV access, you can give them the subcutaneous glucagon. Glucagon can be IM, it can be subcutaneous.
Oh, so it can be subcutaneous too?
I'm sorry, did you say IV D50 is IV push?
Yes, only IV push. Only. Remember, it's acute. Remember, they are going through this process. They are on the fence here. If you don't give them quick, they will die. They
We're
will.
not allowed to give IV push, right?
No, you can't give. Remember, LPNs don't give IV push. Good. Yeah, you can't give IV push. Okay, so diabetic ketoacidosis. Remember, we're still talking about the acute reactions, and we already did this, and we did this, now this. Okay? Diabetic ketoacidosis causes high glucose. When somebody has that hyperglycemia, right? And we said it is common in type 1 person. Okay? And those things that can cause hyperglycemia, like overeating, like stress, illness, same thing. So they're similar. So if you want to know the causes of this is similar to the cause of this. Same thing goes to this. Very similar. All right? And their symptoms, because it's hyperglycemia, those symptoms are similar too. All right? So that helps you to remember them. Okay. Diabetic ketoacidosis, the cells are starving. Remember, the cells starve, they break down the fat, they yield ketones, and ketones are acidic. All right? So insulin deficiency pushes the body to break down fat. All right? Signs and symptoms. Remember, I said it's not good. It must be treated. So it gives them flu-like symptoms. Flu-like, when people are having flu and all those symptoms. And the similar symptoms are symptoms of hyperglycemia, the 3 Ps, right? The headache, the abdominal pain, right? All those things are similar also, because it is a type of hyperglycemia. Now, specific for diabetic ketoacidosis is called Kussmaul's respiration. Remember when we did the respiration, we did the respiratory pattern on that chart, and we have the different breathing patterns, eupnea, apnea, and then we have Kussmaul breathing. That's the Kussmaul breathing, yes.
I'm a little confused. For diabetic ketoacidosis, it says that the causes are high blood glucose. So why would the body break down fat to make it one glucose?
Yes, when the cells are starved, the body breaks down the fat stores to yield energy,
To yield energy, not
to yield energy. And of course, it yields glucose, and then glucose is the source of energy. So that's the breakdown of fat, the components that you get when the fat is broken down. They are stored forms, and they are broken down, and it yields energy. The body uses the energy, but the byproduct, it's like when you give somebody medication and you know the medication has side effects.
But I'm saying that the cause is already having high blood glucose.
No. No.
That's what.
Okay. Diabetic ketoacidosis is yes, yeah. That's not what causes it. That's what results.
Oh, okay.
That's what results, because the cell is starved. It's almost like the cell has zero glucose. And then it breaks down fat. Now it has so much. But then the end product of it is the acidity that goes with the fat breakdown. If they didn't rely on the fat breakdown, they only rely on what we eat, then the ketones won't be there. All right?
So it's the result of high blood sugar.
Result of
Fat
breakdown. Because the cells are starved. The cells have zero glucose, zero energy. They starve. Then they said, what can I do? You know, it's almost like somebody who has nothing and feel like what I can do is to go and steal, right? So they go to the fat to get it, and it breaks down. It yields them energy. The cells now become okay, but then there's something they have to deal with. All right?
I say,
Yes.
the high,
No, okay. Yeah,
because
she explained
the
it.
body starts for
Energy, glucose. The glucose is floating. Okay, if glucose is floating, but insulin is not there to take it, right?
Right, but you're saying that it is because the cause is because it has a high blood glucose.
Remember, the glucose is not being utilized by the body.
Okay,
This person has no insulin.
so this high blood glucose is the result of the ketones, or the result of the breakdown of the fat.
Okay, first, the cells are starved. Let's start from there.
Yeah.
In diabetic.
First, the cells are starved, right? First, the cells are starved. The person ate. It's not that they didn't eat. Remember, they ate. They ate food. The carbohydrate is broken down. The end product is glucose. Glucose is in the blood, but not in the cells, because the insulin is not there. But the cells are there, and they know they have something, and I know I can tap into what I have. That's a fact. They already have a lot of glucose circulating in their body. That's where it is high, but not utilized,
Okay.
not useful as a source of energy, right? So, but the cells know, we already know it's already high in the bloodstream, but not able to get into. So that's why the video that I gave you guys, if you guys were able to watch it, it tells you how the insulin drives it into the cells. It's really so good, you know. So it tells you what happens. So because of that, that's why when you check their glucose, they get 300 or more. And you will now say, oh wow, let me see if my cells broke down the fat and now I have byproducts of ketones. Already I checked the blood sugar, it's high, it's 300, right? You get that? So it's already high. But because they are type 1 people, they don't have enough insulin, or they don't even have insulin to take care of, to drive the glucose out of the blood. Then the fat breaks down and has the byproduct. You get that? So specifically for type 1 person, they have cosmos respiration, cosmos breathing. It's also called acetone breath. So the person with type 1, when they are in ketoacidosis, this is typical for ketoacidosis. They have that deep breathing, okay? And it is acidic, right? Acetone breath. They have acetone breath. Cosmos respiration yields acetone breath, okay? Fruity breath, it's like fruity breath. They have electrolyte imbalance. Remember, flu-like symptoms, some vomiting, dehydration. It's high sugar. It draws water from the cells. They feel that dehydration, right? The thirst, the excessive thirst. Dehydration. Dehydration is not good. Remember, when somebody doesn't have enough, because they have so much sugar, it draws up all the water they have in their cells. And if you don't replenish, dehydration will complicate issues. They have too many things they have to deal with. You see what I'm saying? It's like so many things. That's why diabetics really deal with so much. So they're not only dealing with the fact that they're losing fluid, they don't have the energy, right? Their body's not using. They're also dealing with the fact that there are electrolyte imbalance, which, right, when your sodium is too low, potassium is too low, or too high, too low, not good, not good. It complicates things. We don't want diabetic ketoacidosis. Remember, I'm saying having ketones is not good. It must be addressed, right? They can go into coma. Dehydration can lead into hypotension, low blood pressure, right? And that will cause somebody going into coma, all right? So it's a lot of things that can complicate issues. It needs to be treated, all right? Therapeutic intervention for all these except this one, okay? This, hyperglycemia, DKA, hyperosmolar. This is intervention for them. So that helps you to remember it. You must give them a lot of fluid. You want to dilute with so much sugar. Give them fluid, insulin drip. They have to be on insulin drip. Because it may be 300. But people can be as high as 1,000. All right? 700. High. And you need to bring it down. It's causing damage. All right? So if it's 300, but if it's really, sometimes 500, 600, they put them on insulin drip. So insulin drip, you get a bag of IV solution, not dextrose. They have different IV solutions. Some are dextrose solution, normal saline solution, lactated drinkers, different ones, right? Has to be normal saline, no dextrose solution, because they're already dealing with high glucose. So you don't want to be giving them dextrose solution by IV. Now, that normal saline, a bag of 1,000, a liter, they inject whatever amount of insulin the doctor orders, inject it into that bag. They now give it as a drip. That's an insulin drip. Because they are constantly getting insulin, remember, you now have to monitor them frequently, frequent glucose monitoring. This is the kind of patient you have to check their blood sugar maybe every hour. The doctor will order it every half hour, every hour, you can check it. You're going to be busy with that patient who comes in DKA, all right? So, frequent glucose monitoring, electrolyte monitoring. They'll be drawing their blood also to check their electrolytes, all right? Prevention is the best. If we can prevent it from happening, make sure they eat, make sure they take their insulin when it's appropriate. If they do exercise, let them have some fast, So, encourage them to drink fluids. They can drink fluids, keep on monitoring their blood sugar. When they are home and they get, they do a dipstick and they get ketones, and the doctor will say, continue to monitor it. They have to check it more frequently. They may need to go back to the doctor, Important thing, remember, what's the most important thing? No fluctuations. Regularized level. Remember that. Good diabetes control. That's what they want. Okay? Now the other one, which is the hyperosmolar hyperglycemia. Remember? They are all acute reactions. The treatment we just passed, the same treatment, so you can remember it. IV fluid, insulin drip, same as this. That's why I group them together so you can remember them. All right? So stress, again, hyperglycemia as in type 2. Illness. This is more common in the elderly where you get a hyperosmolar. Not only elderly, you get people who come in with 1,500 blood sugar. All right, that's hyperosmolar hyperglycemia. It used to be called used to be called hyper or smaller hyperglycemia non-ketotic. I know, no ketones, that's what it means, non-ketotic. But don't worry about it, that's not mean. Just worry about the correct name. No ketones. So to differentiate it, they're less likely to have ketones. All right? So same thing, they have those symptoms of hyperglycemia, polyuria, profound dehydration, polydipsia, right? But it is not associated with nausea, vomiting, like in DKA. The flu-like symptoms, they don't have the flu-like symptoms like here. All right, so this one, they have nausea, vomiting, and some of those flu-like symptoms, but here, no. And that's the reason why they don't have symptoms, right? And also, they stay longer, they take too long to go get help because they don't have the acidity that makes them sick. So people can walk around with 1,000, they're not too sick, except too thirsty, go to the bathroom. So they take another week before they go to the doctor, all right? So they take longer to get help. Signs and symptoms, same thing as hyperglycemia, okay? Remember we're saying here, blood glucose can be up to 1,000 to 1,500, all right? They can go into coma, coma from that too. So too low, too high, they go into coma, all right? Same thing I told you, IV drip, same as the other one, insulin drip, IV fluid, and then electrolyte monitoring and frequent glucose monitoring. Prevention, they need to know about self-monitoring, right? They need to know that, self-monitoring of blood glucose. When their glucose is rising, remember we're saying for 2 days or more, they have elevated ones, right? They're having all of a sudden higher levels, greater than 180, they need to call the doctor. If their glucose is rising and it's not their usual numbers, and 2 days consecutively or more, they need to call the doctor. All right? Long-term complications. Remember, I was talking about all these complications this whole time. They suffer from 2 major complications that you need to familiarize yourself with. One is macrovascular. That's major, big blood vessels. That's why those ones can cause stroke. Macrovascular, that means big blood vessels, right? Like coronary arteries. Those things get damaged. And they can have stroke. The ones that supply the brain too. So people can get stroke, they can get MI, myocardial infarction. Because the complication starts damaging the blood vessels, starts damaging all the nerves. Over time, these are the patients who are at risk for developing stroke and MI. All right? Chest pain, MI, because their blood vessels have been damaged. Peripheral vascular disease. They have peripheral vascular problems. Their feet. That's why they have amputations. All right? Now, you have the micro vessels, the smaller blood vessels, not the large vessels. We worry about the retina, the supply, the tiny vessels that supply the retina. It gets messed up, they go blind. A lot of diabetics become blind from retinopathy. All right? Nephropathy, the vessels that supply the kidneys get damaged. Doesn't give adequate perfusion to the kidneys. They end up with dialysis. So many diabetic patients have end up with dialysis. Then we have neuropathy, the nerve pains. We have nerve pains. That high level glucose damages their nerves. So they lose the sensation because of the neuropathy. Prone to infection, food problems, right? They want to make sure they don't hit anything or step on something that can cause injury, So they need to understand this. When we plan teaching for the patient, you gotta let them understand. You must wear your shoe all the time in the house. Don't be walking around barefoot, all right? Especially when they have neuropathy, okay? Diabetic foot ulcer. Once they get a wound, it doesn't heal. It takes so long to heal. So the ulcer, just stays there, worsens. They'll be treating it, but it doesn't go away like that. All right, so they don't want the just at the time that they see any opening, they need to address it quick enough so it gets so big so quickly.
Are they able to feel at that point?
They don't feel much. They lose a lot. That's what I'm telling you. From the time they're diagnosed, 10 years later, 15 years later, by the end of their lifetime, they may end up with amputation. Peripheral vascular problems. Perfusion to the lower extremities. A lot of them, they don't have adequate perfusion. They don't have adequate nutrients flowing to those areas, so it doesn't even heal. They have organisms that are, ready to go in and be feeding on that sore, and it doesn't heal.
That's only type 1 or that's
Both diabetes, whether type 1 or type 2. They all have the complications of macrovascular and microvascular. There's a lot of them. So there's a risk, all right? Foot care, something important for a diabetic patient. They must know to take care of their feet and assess it daily. Inspect their feet daily, right? Wash and dry the feet, especially between the toes. Don't keep it warm. If it's moist and moist, right? Organisms can grow there, right? So dry between your toes. When you get your diabetic patient, take good care. Wear well-fitted shoes. They have peripheral vascular problems. They're already compromised. So they must wear well-fitted shoes, not the ones that will be too tight on them. It can develop a sore from a tight shoe. They wouldn't have adequate perfusion. They already have problems. So they need to have good socks and good fitting shoes, right? Protect the feet. They don't want to step on anything, right? Avoid crossing their legs. It's already compromised. They want good perfusion. When they cut their nails, they have to be extremely careful. They don't want wound, no wound. Their toenails, they have to go to a podiatrist. All right, they need a podiatrist. They need a podiatry care every, every year or every 6 months. 6 weeks? No, not 6 weeks. 6 months? Oh, well, to cut it, if you've been cutting it, but they need to make sure they go to a podiatrist, right? CMD, immediately they develop any sore. They need to call their doctor, right? So if they're going through surgery, remember we said stress. When you have to go to surgery, is it not an anxiety causing thing? They're so stressed out. So it is expected that their sugar will go up. So that's the time we expect. Their usual dose will have to be increased. They have to be increased. So they won't be on their normal dose. They will have an additional dose. So those people who get routine shots and they just get 5 units every day with their food, they may need a sliding scale. That's why I know a lot of people with type 2 patients who are only on pills. When they come to the hospital, acute hospital, right? They put them on sliding scale. And a lot of them will say to you, I don't take insulin. But when they come to the hospital, it's expected that it's a source of stress. And so they put them on sliding scale just in case they need it. All right? Sliding scale insulin or insulin drip if they're going to go to surgery. If it's so high, and then they be on insulin drip. Monitoring their blood glucose levels, especially when they are critically ill, right? Nothing diagnosis.
Skip one.
Huh? Did I skip one?
Skip one. Hope for
Which one?
Hope for the future. The one before patient, for care of patients.
Yeah. Which one?
Oh, you don't have it.
You don't have.
I don't have. What is it? What does it say?
Hope for the future.
DCCT, time control reduces complications of UKPDA.
Oh, HbA1c.
You discussed that already.
Did I discuss it
Yeah,
already?
HB, yeah, what was the thing that was 72.6%?
Oh, hope for the future. Oh, tight glucose control. Remember? And remember hemoglobin A1C. Yeah. But remember, to decrease fluctuations, you don't want fluctuation. So tight control is what they need without fluctuation. That's just what that is, right? Nursing diagnosis. What about non-compliance? Some people are non-compliant. Knowledge deficit, right? Perfusion, impaired perfusion, sensation, loss of sensation, right? So many that you can come up with. Electrolyte imbalance. There's so much. Nursing diagnosis, right? Diabetes self-management education. So plan good education for your patient. They need to understand the disease process and what's going on. They need to understand why they need the insulin, right? They need to understand if it's going to be pill, why they have to be. They need to understand why they must modify their diet or incorporate exercise in their lifestyle. So these are the things you need to teach your patient, for patient education. How they can go home, because they're not there, the nurse is not there every day. They need to understand what to do, right? Medications to take and how often, remember the time of onset, the peak, so you gotta teach them all those things. Acute complications, and they may experience hyperglycemia, they may experience hypoglycemia. These are the symptoms. These are, the treatment, what they need to do for that, right? Chronic complications, these macrovascular, right? That's the complications. So it's something that some diabetics cannot avoid, having those micro or macrovascular complications over time. But what the goal is try to control the decrease fluctuations. It kind of holds back the time, at least it extends the length of time it takes before they develop all those complications. All right, so, and what else is there? Health promotion, psychosocial adjustment, just having to monitor their sugar every time they have to eat. It's draining for people, especially when it's new diagnosis. All right, you have a question?
What's the SMDG?
Self-management of blood glucose. We had it on another slide. All right. So then there's reactive hypoglycemia, sympathetic response, hyper-responsiveness of the pancreas. So the pancreas, remember the homeostasis, something goes up. So the pancreas, the complication is off. So pancreas is producing more insulin, and it drives all the glucose into the cells. Now they go into hypoglycemic, okay? So it's just, another abnormal problem that may occur, all right? So sympathetic fight or flight response. Therapeutic interventions, more frequent meals. You don't want to eat one large meal now and a small meal later. Small portion, based on how many calories are they ordered for them. Regularize, no fluctuations in your glucose as much as possible. High protein diet, less carbohydrate, right? Less carbohydrate diet. Wow, like so long.